Very much indeed for this invitation to give the talk in the GIS valves program. My focus is going to be on muscular VSDs and in particular post-infarction VSDs and how to close them. These are my disclosures. The ventricular septal defects are really, majority of them are congenital and majority of these are perimembranous. There's about 10 to 20% of all the VSDs are muscular. And then less frequently seen are the traumatic acquired ones or the post-myocardial infarction ones. The VSDs, especially the muscular ones, are classified into different areas of the septum. So they can be from base to apex. They can be in the inlet part, in the mid septal or mid muscular part, and towards the apex. When we close the VSDs in the catheter lab, there is a requirement to have an adequate size of the patient in whom we can insert the appropriate sheaths. Access tends to be venous and arterial and very rarely transhepatic. When we implant a device, the valve function needs to be preserved, especially the inlet valves, but also the arterial valves. And the technique should be as safe as surgery, because surgery will be available as an alternative in a lot of these. The location is in the inlet trabecular or outlet septum. We have to, on the imaging, assess the proximity of the AV valves and semilunar valves. And so excellent echocardiography is essential. We use round, self-centering, repositionable and retrievable devices such as the Amplatz or Occlutech muscular VSD device. One of the prime considerations is that the VSD should be hemodynamically significant. Here are a couple of pictures of the Amplatz muscular VSD device and the Occlutech muscular VSD device. And this is the Amplatz post-infarction VSD device. And when we select these devices, they should be at least 1 to 3 millimeters larger than the largest diameter of the VSD. The technique involves establishing an arteriovenous loop from femoral artery to femoral vein, from femoral artery to the right internal jugular vein, and that depends on the location of the VSDs. And very rarely hepatic vein access is required. Sometimes veno-venous loops are performed from the femoral vein to right atrium, left ventricle, crossing the VSD to the right ventricle, back into the right atrium, and then wire snared out from the internal jugular vein. In adults, especially, but some older children, the left ventricular approach is such that we don't need an AV loop. The defect is crossed from the left ventricle, and then the sheath is advanced over the wire. And this is a technique that is less frequently used. If you use a non-braided sheath, they may kink, but braided sheaths tend to not kink. The sheath size is relatively large for infants and children for the femoral artery, and therefore this technique is used in more adult patients. Here are some pictures of a mid-muscular VSD. You can see a defect that's around 7 millimeters at the right ventricular end, with a left ventricular opening of around 17 millimeters. The defect is crossed from the left ventricle with a Terumo wire. And in this case, the wire has gone up to the right atrium and then SVC, where it is snared. Then you can snare that from femoral vein or the SVC, depending internal jugular vein, depending on the location of the defect. In this case, from the femoral vein, the wire circuit is established. Then a torque view sheath is passed over the circuit into position in the transverse arch before the circuit is broken. And here you see a muscular VSD device partly open in the ascending aorta, drops into the left ventricle, and then the disc is opened properly. After that, after some check angiograms, the right ventricular disc is opened like so. Once we're happy, check angiograms are performed, and if the position is good, then the device is released, as you'll see there. And there's the final angiogram showing an excellent result with minor leak through the defect, through the device. Multiple VSDs can similarly be tackled. Here are some still pictures of multiple apical and mid-muscular VSDs. Here, one device is deployed, and here, after a second device, there is a residual mid-muscular VSD, and then a third device is deployed here, and there's a much smaller residual shunt. In the literature, if you pull the results, the muscular VSDs are occluded successfully in 98 to 99% of the cases. There tends to be a residual leak immediately at the end of procedure in 20 to 30%. At 6 months, this reduces to 10 to 15%, and at 1 year, 3 to 10%. And here you see a muscular VSD device in place. I'll focus more on post-infarction VSDs now. These tend to occur in two positions. One is in anteroapical region and the other in infrabasal septum region. The anteroapical is more commonly encountered, and it's usually easier to understand it anatomically and is associated with a better prognosis. The infrabasal defects or ventricular septal ruptures are less common. They're often very complex defects, and infarction often involves the right ventricular wall as well, and there may be odd septal rupture with false aneurysm formation, and these patients do fairly badly clinically as well. Imaging is essential. Here we see a transthoracic echocardiogram showing a anteroapical VSD or ventricular septal rupture, as you can see here. And then here there is an infrabasal rupture or post-MI VSD. And here there's an even more complicated septal rupture into a false aneurysm resulting in a left or right shunt as well. Even better understanding can be obtained from CT or MRI scans. Here's some CT scans showing a complex ventricular septal defect, which is about 13 millimeters on this view. But on end-on views of the septum, you can see that the defect is much bigger, 32 millimeters in this case. And so that is going to be very, very difficult to close by devices. So CT or MRI CT scans in particular are very important, provide additional information. Here's a post-infarct VSD in whom there is an intramyocardial dissection and rupture with false aneurysm formation opening into the right ventricle. And with a muscular VSD device in place, you can see it in a satisfactory position from the left ventricular view, but elongated in the right ventricle. Natural history studies back in 2000 in Circulation and JACC showed in one study, the Gusto-1 post-infarct VSD study of patients that were medically treated, showed a very high mortality, approaching 94% at 30 days and 97% at 1 year. And then another study, SHOCK, which consisted of medically treated patients, the in-hospital mortality was 96%. So medical treatment is not very satisfactory. And this is how interventional treatment was developed, although surgery remained the gold standard, albeit high risk. The first description of in 1988 was of a lock clamshell device to occlude the ventricular septal defect post-infarction. And since late 1990s, better devices such as the Amplatzer VSD devices have been used. And these are available up to 24 millimeters. And there are some larger devices available as the so-called post-infarct VSD occluders. Here's a historical picture of a 73-year-old with the post-infarct VSD towards the anteroapical region. This was closed with two CardioSeal devices, as you can see there in the still picture. And there's the still picture of an angiogram at the end of the procedure. Here's a 70-year-old with a post-infarct VSD in a bit more in the mid-trabecular or mid-septal region. The defect is around 13 millimeters, as you can see here from the measurements. In this case, the VSD is crossed from the left ventricular side. The wire, the truma wire, is then passed up into the right ventricle into the pulmonary artery, where it is snared from the internal jugular venous approach, because this is a defect that's a bit low septum. And then a sheath is advanced up over the guide wire circuit into the left ventricle. And then the VSD device, in this case for a 13 millimeter defect, an 18 millimeter VSD device is delivered, gradually opened into position, and then right ventricular disc is deployed. After check angiograms showing satisfactory position, the device is released. And there's the final angio with a small residual leak through the mesh of the device. Surgery, as I mentioned, carries a high mortality. So various studies show a mortality of around 40 to 50%. The SCTS database between 1999 and 2010 of nearly 3,000 patients showed an early mortality of around 43%. If you could delay the surgery for more than 3 weeks, more than 21 days, then the mortality rate falls to less than 20%. And so that is, in a way, if you like, a process of natural selection. Here's a 69-year-old patient with post-MI VSD of about 8 millimeters, in whom a 12 millimeter Amplatzer post-infarct VSD occluder was deployed and then released. And there's the final angiogram showing a little bit of residual shunt, but a satisfactory position nevertheless. There are some defects that can't be closed if they're more than 2 to 2.5 centimeters, if there are multiple holes, if the defects are in a position where a device will interfere with a valve, such as the infrabasal ruptures, and then when there's extra septal rupture, which is much more complex. A UK retrospective study from 11 centers, 53 patients, was reported back in 2014. 19 of the patients had had previous surgical closure. The delay or the time from infarct to VSD closure was 13 days. 89% of the procedures were technically successful. Around 4% of the patients died, and nearly 8% of them required emergency surgery, and some of them required later surgery because of hemolysis and device embolization. The survival to discharge was 58%, so there was 42% mortality, and a further 8% of patients died during the follow-up. And there's the summary of the literature on post-infarct VSDs, and the pooled analysis shows that 48% of the patients were in cardiogenic shock at the time of the treatment. Procedures were successful in almost 90% of cases, but there were complications with the procedure of 13%, and in hospital or 30-day mortality was around 32%. So still high mortality, but not as high as some of the studies, especially surgery. There was a study from Bristol from Mark Turner's unit with Mark Hamilton as the first author, which focused more on the VSD morphology. There were 32 post-infarct VSDs evaluated by CT or MRI scan. They tended to be large with a mean maximum diameter of 27 millimeters, and only 22% of them were entirely confined to the septum. And interestingly, the waist of the largest Amplatzer muscular VSD would have filled in only 50% of the defects. And so here's a flow chart, which is slightly complex, but a simplified one shows that if post-infarct there is ventricular septal rupture and the patient's hemodynamically stable, then you can, and it's beyond 7 days, then you can delay the surgery and do it at a more stable time. If the patient is on mechanical support and is stable, again, you can delay it. But if the patient is unstable either on mechanical support or unstable anyway, and if he or she is candidate for surgery, then emergency surgery is performed. But if he or she is not suitable for surgery, then, and the anatomy is favorable, then consider percutaneous closure and reconsider bailout surgery if required. So that's a rough sort of algorithm of this condition. Generally, however, the patients may be unstable and require surgery or catheter closure within the first 2 weeks, and that produces a better survival. Whereas if they're stable, then you can delay that beyond 21 days. I'll stop there. Thank you very much.